Okay, we're going to start because we have a wonderful panel of experts that are working here in the San Francisco community. And I have the pleasure of moderating this particular panel. We have the next hour, half of which we're going to ask some questions and have a conversation with the panelists, and the other half you're going to be able to ask the questions. And so you'll see that there are some index cards on the table. We're going to ask you to, write your question down and hold them up, and runners will come and get them. We would love to be able to have you ask your questions, individually in person. However, this particular facility is not amenable to having a lot of extra media equipment, and we don't have enough mics to be able to do that. So if you could write your question down, and then we'll be happy to address them in the second half. So this is the Caregiver Experts Panel section, the local experts, a professional experts panel, excuse me. And I'd like to introduce Kelly Dearman. She's the Executive Director of the Department of Disability and Aging Services. We call it DOS, so you hear that acronym, that's what it means, under the San Francisco Human Service Agency. And then Anna Chodos. She's a physician, assistant professor of medicine, Division of Internal Medicine, and geriatrics at UC San Francisco, and she's the director of the Geriatrics Consult Clinic and Geriatrics Neurology Cognitive Clinic at, I know it's called something else, but I always call it San Francisco General. I just can't put Zuckerberg in there. Sorry, just can't. Then I would like to introduce Wagata Samiri. I hope I'm not mangling your name. My apologies. She's Assistant Professor of Medicine, Division of General Internal Medicine, also at that San Francisco General place. And she's a primary care provider in the clinic there. And lastly, at the end of the table is Emily Chum. She's the Director of Social Services for Self-Help for the Elderly, and a particular agency that we work closely with at FCA. So I'm going to just open it up by asking this question. What are some of the approaches and strategies that the city and county of San Francisco can do to raise awareness about family caregiving, especially in underserved communities and communities of color? And there's no particular order. We're going to pass the mic.
We're going to have them each do a little presentation.
Oh, I'm sorry. I'm sorry, I didn't read that far down in the memo. I was just going to start off and just ask them questions, but no, actually each of the panelists are going to do a really brief presentation first to talk about their work. My apologies.
Okay. I'm going to move the podium back a bit so we can see how.
Okay, can you hear me? No?
Yeah.
Can you hear me?
Go a little further.
No?
A little further.
I mean, I can hear me, but can you hear me? I don't know.
Okay.
Good morning. Good morning. I'm so happy to see you all, and I'm so happy to be here in person. I'm Kelly Dearman, and I'm the director of DOS, and I've been here for a little over 14 months, and I'm really enjoying it, and I'm loving all the people I get to meet, and will tell you that the professional is very personal for me. I live in a house with my parents and my kids and my husband and a cat, and my parents' room is off of the kitchen. So every morning when I go up to the kitchen to start the coffee, my 86-year-old mom says, "Who's in the kitchen?" And I say, "It's me." "Oh, good morning, Kelly." And I say, "Morning, Mom. Don't leave before I get to see what you're wearing." And I'm Okay. And then I say, morning, Dad. Morning, Kelly. How you doing this morning, Dad? Reasonable. Okay. So that is my conversation every morning that I've been having for 12 years. And I feel so grateful and appreciative, not only for me, but for my kids who have this relationship with their grandparents that is amazing. But for me to get to see my parents who have been married 62 years, and the love that they have for each other and how they treat each other, it's not always, bells and roses, but mostly it is. And my mom, who has dementia associated with her MS, my dad, you wouldn't know that was a thing. He's fine to just repeat himself. He's fine. He looks over at her. We'll be having dinner and he'll say, "You look so beautiful today, Ina." You cannot buy that. And so I come to this work from a place of just loving my community and we have had the same caregiver for my mom for the last 12 years. So she's another member of the family. And I just say that you all caregivers are the true heroes. And I'm just so appreciative of what you do every day because it's hard. I do caregiver adjacent. I do the management of it, all the doctors, all the blah, blah, all that. But the hands-on care, I don't know how you all are able to do it every day, and I just want to thank you. If you don't hear thanks enough, just know that I said thank you, thank you, thank you. So about DOS, I have to put my glasses on because I can no longer see. So most of you know about DOS, that we're the government agency charged with coordinating services for older adults, veterans, people with disabilities and their families so that we can maximize their safety, health, and independence. We serve 70,000 unduplicated clients throughout our department programs and through our community partnerships. So we have a budget this year of about $483 million. We have 439 employees, and we contract with over 60 community organizations to deliver services. So in terms of our priorities that pertain to caregiving, our recent annual report highlights key achievements in the past year and outlines our priorities for the fiscal year 22-23 to support older people and adults with disabilities to live safely and to be able to engage in our community. So for informal caregivers, we have we want to enhance mental health supports for informal caregivers, including expanded capacity for individual counseling and support group services. Oh, sorry. Oh, yeah, look, I just went away. Okay, just let me know. It's I can't really see, so, okay. All right, for our IHSS caregivers, we're trying to improve resources, including improving business processes for in-person and phone services at the Independent Provider Assistance Center and developing a new orientation video for new providers. And we want to help IHSS independent providers to access new and existing paid training and skill development. In terms of advocacy, we're advocating for statewide legislation allowing all adults, regardless of documentation status, to work as an IHSS independent provider in order to expand the caregiving workforce and access to this critical economic support for low-income individuals. So for our Dignity Fund allocation, which I think Kathy talked about a little bit, for this year, we have $200,000 in the caregiver support service area to improve outreach, education, and support for caregivers, and also money for mental health support for family caregivers. We know that your emotional and mental health is pivotal in all of this, and we seem to have ignored it for a really long time. In terms of IHSS, Our in-home supportive services program is one of the best tools that we have in California to support family caregivers who provide daily care to their loved ones. You all know this is a federally and state and locally funded program that serves over 25,000 older people and adults with disabilities in San Francisco alone. The majority, 57%, of IHSS consumers in San Francisco have chosen a family member or other loved one to serve as their caregiver. That's all of you. In San Francisco, our IHSS program is striving to meet the diverse needs of IHSS caregivers. We work in strong collaboration with the IHSS Public Authority, that's where I was previously employed, and they provide a wide range of services to IHSS caregivers. They're actively enhancing their one-stop shop service center for caregivers. And additionally, they can connect IHSS caregivers with training and connection to health and dental benefits. So the last thing I'll say is that the state of California has recently taken an unprecedented step to expand access to Medi-Cal and related benefits, including IHSS. This past May, individuals over the age of 50, regardless of documentation status, became eligible for Medi-Cal. And in July, eligibility for Medi-Cal was significantly expanded when the asset limit changed from just $2,000 to $130,000 for an individual. And looking towards the future, Medi-Cal will be doing away with the asset limits altogether, making eligibility much easier. These Medi-Cal expansion efforts provide new opportunities for family caregivers who may not be receiving compensation for the care that they provide. I encourage anyone who resides in San Francisco to reach out to the DOS Benefits and Resources Hub to explore eligibility for Medi-Cal and IHSS, as well as a range of other caregiver support services. And shout out to the DOS booth over there. You can go and talk to them if you haven't spoken to them already. I thank you all for being here, and I really appreciate this opportunity. Thank you.
Good morning, everyone. I'm Anna Chodos. Let's see if I can get the volume correct. I COVID tested twice this week because I went to Texas to see my mother for her 80th birthday. And so my parents at the moment do not need a ton of hands-on caregiving, but I feel proud that we're starting to have those conversations, especially since they live so far away. But as Kathy mentioned, I am a physician. I do geriatrics at the General, outpatient, and I have it's a little overly described, our geriatrics cognitive clinic, but it's a dementia clinic. So most of my patients have dementia. I mostly work with older adults, I would say middle-aged and older adults and their care partners, support systems when they have dementia. So that's my experience. That's where I'm coming from. I'm incredibly honored to be here today. I mean, just looking at the tables around the room, these are all the organizations that I admire deeply. I'm always trying to connect people to, and I really admire all the work that everyone does here to support the people they care for or care with. And I think I really wanted to start out with an acknowledgement of what Kathy was saying earlier, that healthcare does a horrible job of really acknowledging the work that caregivers do and connecting them meaningfully to services. It really is the work that everybody's doing here that makes those connections really happen. And so I think myself and my colleague, Dr. Semere, are probably going to talk about, how some of the challenges and how we hope to partner better. So I also, as part of my job, get to teach. That's one of the nice benefits of being in an academic place. And I teach our residents, I teach my colleagues in primary care. And the things I like to point out about working with caregivers is we know just awareness, frankly, awareness of these roles, awareness of needing to bring that into the visit. So how do you ask people about what their role is? How do you ask people who's in their lives, who's supporting them? And then how do you acknowledge that? You know, don't just note it or hand them more papers or give them more things to do. Really taking a moment to acknowledge that work, acknowledge how foundational that is, how integral and involved that work is, and then really working with them to figure out what's going to work for them to support and expand their capacity. You know, help put a little, sometimes I describe it as pillows around them, sometimes I describe it as wind beneath their wings, although I don't feel like as many people get that reference as, for some reason I think they should. But we can't just look at caregivers as a bottomless resource. You know, they need support, they need additional help as well. And so how do we really work with the person to find ways that they can accept and bring additional resources into usually we talk about it as a dyad, like two people, the caregiver and the person who's getting some support. The thing I see time and time again is that caregivers really don't have a lot of bandwidth. I think it really gets to the fact that most people are still working, or the person they're helping to support requires a lot of hands-on support, and in a really great way, they care a lot. In a really challenging way, that means sometimes they won't accept help from other people coming in or other resources. And then I do a lot of acknowledging that in healthcare, I've been really horribly trained to know how to help caregivers. And that I don't have the personal experience as a caregiver, particularly in San Francisco. So I really, every single time I see them, try to encourage them to connect to all these wonderful resources in the community where they can meet other caregivers and meet experts. I don't know, I would be interested to know how you guys feel about what I'm gonna say next, but I do encourage caregivers to accept that role as an advocate. Point out to doctors and healthcare providers that you're part of the equation, that you need to be involved in a way that works for you. Because often when I'm training or observing people who are still learning medicine, they're just handing stuff over to that caregiver as if they, understand these ridiculous pieces of paper that come flying out of the computer when a visit is over, with lists and way too many pictures and way too many confusing details. And often the physicians or other members of the healthcare team don't actually know how to work with a caregiver. So it's really okay to speak up and tell them, this isn't going to work for me, or I don't really understand what you're trying to tell me right now. Am I supposed to change the medicine? Am I supposed to not change the medicine? Whatever the case may be, because those healthcare teams I assure you, have no training in how to talk to caregivers. And then finally, I just want to say we are really open at the place that shall be called by the name San Francisco General. We're very open to input, and particularly in the geriatric services. So I very openly encourage you to contact me. But we also have a new program that is a statewide program to serve Medi-Cal patients, where our target is providers and healthcare teams in primary care. It's called Dementia Care Aware, and our website is not perfect yet. It's going to be perfect soon, but it's dementiacareaware.org, and our email is dca@ucsf.edu. Oh, see, there we go. These are good advocates. I commend you. So the email is dca, the letters, at, like FCA, actually, dca@ucsf.edu. And we're really proud because our core mission is to train primary care to do a better job at detecting dementia early. But we start with something called the cognitive health assessment. And in that very first moment that takes 5 minutes, or so we say, we hope it's really true, they're going to assess the patient's cognition, function, and if there's a support person in their life. So we're starting out right out of the gate saying, this is a foundational aspect of knowing about somebody's cognitive health, because it's how you're going to help work with that person and their support system. And also how to note and document if there's not an informal or formal caregiver or care partner or someone who's helping them with anything. That's a lot of people as well. So then how do we connect people to all of the wonderful resources county by county? So we're trying to do that as well, make it really county relevant. So we welcome your input and your strong opinions. We welcome your cheerleading and any collaboration. But please, I really welcome any connection with you and just want to say thank you again.
Good morning, everyone. You hear me okay? Good morning. So first of all, thank you for the opportunity to speak with all of you. I'm really honored and humbled to be here and learn from all of you and the expertise that you have. A bit about me and how I come to this space in caregiving. So my family came here to America as refugees from East Africa. Can you hear me? Is that better? Okay, I think I got to get really close to this. So, okay. So we came to this country as refugees from East Africa, and as my parents acclimated to being in America, I think one of the greatest challenges they faced was navigating the healthcare system. And at a young age, when I was about 12 years old, my father suffered a severe stroke, and I was pulled in to be medical interpreter and accompany my father to medical visits when my mother couldn't be there, and help at home. And I remember feeling very overwhelmed by this role, and also very aware of the importance I held in the room, simply by being there, and also by just being able to communicate and speaking English fluently. And I remember thinking, there are other important voices, my father's, my mother's, but she couldn't be there because she was working, and she might not have as much ease in communicating with the doctors and the nurses and the therapists. And so her voice wasn't heard in terms of how she managed diet, cooking at home, lifestyle, and things that were really integral to his recovery. And she also wasn't supported in the ways that she could have been. She wasn't encouraged to manage her own health, her mental and physical health, and to care for herself. And that experience stuck with me for years. And I remember thinking, there have to be ways that we do this better. And it drove my interest in really trying to understand how we support individuals in the healthcare system who face language and cultural barriers, and how we bring their family into the picture. I continue to be a care partner for my parents and help them navigate ongoing medical issues. Fortunately, they are still alive and doing well, but I have found that I do this now, and I come to this as a physician, and I have that advantage and expertise of being an insider that my patients don't have, their caregivers don't have in many instances. And even with that, it's hard. I'm still baffled by many of the things that Dr. Chodos pointed out that we do not do well as a healthcare system in terms of how we prioritize the voice of our patients and their caregivers. I've had to learn how to be an advocate for my parents, but also teach them to advocate for themselves and know when to step back. And that's also something that is an ongoing process for me and is hard to do. And so, as Dr. Chodos mentioned, one of the advantages of being at an academic institution is being involved in teaching and also research. So I have a role in which I'm able to do some research around some of these issues and understand family caregivers. And one of the experiences I've had is in speaking to primary care physicians in different healthcare settings in California, where they're primarily serving racially and ethnically, linguistically diverse populations, many low income, and talk to them about what it's like to engage with patients who have caregivers. And some of the things that we've heard are that they value and see the importance of supporting caregivers, that supporting caregivers is truly the best way to support their patients and improve their health. But even in recognizing that, they feel that they are not equipped, as we've talked about, to do this effectively. And much of that has to do with not having systems in place to recognize and identify the caregiver in the room. How do we start out by saying this person has a caregiver, a support person, and make sure that that's known to all providers, that that's something that's carried through the health record? How do we think about communication in the space of bringing in the caregiver? One of the other areas I work in is thinking about how we use the electronic health record. And so trying to engage caregivers to sign up, to use MyChart when they're able, to communicate with physicians, and help them do that in an effective way. How do we compensate and help providers find the time in their schedules to engage with caregivers? One of the hardest experiences is if, for instance, you're taking care of a patient with diabetes and you've invested all this time into talking to them about how they could manage their diet and how you want to adjust their medications. And several months later, you learn that they don't manage their own diet, they don't manage their medications, and they have a caregiver who does, who hasn't been in the room. So how do we think about interceding early on, supporting doctors, helping them feel comfortable in bringing the caregiver into the conversation, and once they do, feeling equipped to support that caregiver. And I think that is a challenging process. We don't have all the answers. I think that many of you have answers that can help us do that better. And it's something that I hope that we can continue to improve upon in the future. All right.
Hi, good morning, everyone. Can you hear me okay? Hello? Is it better? Okay, great. I'm so happy to be here, and this is the first in-person conference and since the pandemic, and I'm so happy to be here on behalf of Self-Help for the Elderly. So first, a little bit about myself. My name is Emily Chum. I'm the Director of Social Services with Self-Help for the Elderly. We have been supporting caregivers through that take care of their family members. And the majority of our clients are monolingual in Chinese or very limited in English, who faces challenges on caregiving at different levels. And as an immigrant of myself, I came from Hong Kong. And during my college year, my grandparents, who was very supportive, I always stayed at their house when I was little. I grew up with them. So after I immigrated to here and facing a very difficult family decision, whether they should stay in Hong Kong or they should stay in here. And my grandfather had a stroke. My grandmother is a very tough woman. She's a Chinese doctor, and she's a doctor, so she would always take care of all the medical stuff in our house. So at that time, we focused on our grandfather, and so we kind of seek for resources in America and see if they should stay in here. But at that time, we didn't know much, so we thought in Hong Kong if they have better care. So they stayed in Hong Kong. But if I know all the resources as of today that I know, I would really have to have them to stay here with all the resources and assistance that we can have in here. And I know I can be regrets, but I'm here, and hopefully we can provide all the resources and assistance to all the caregivers to your job to make no regrets decisions. So since most are the caregiver that we serve facing language barriers, and our family caregiver specialists who are bilingual and also cultural sensitive to not only the language, but also the family dynamics, the culture behind that, and to help them to make the right decisions in different settings. So one of the barriers they face is navigating the healthcare system. And for example, one of the clients that we work with, and she called 911. So she is advocating for her mom and called 911 for her mother. So when the paramedic came, she wasn't able to communicate. She wants to tell everything to the paramedic officer, what happened since when, but she couldn't. And she was so frustrated, so she drove along, followed along to the hospital. But the on-site translator wasn't available at that time at hospital. So she was waiting, and she doesn't know what the diagnosis, what they're gonna do. Is that CT scan? Like, what happened? She keeps throwing up, and she got very frustrated. She started to bring on herself. She was so angry that she doesn't speak the language, and she called us right away. So we were able to link her to the on-site translator and also help translate for her. But when she get home, she wasn't able to understand the medication. So we let her know that what that medication was for, and then provide assistance and also emotional support to her. And because most of the caregivers that we serve, not only facing language barrier, but they also are considered low income and work longer hours job, and they usually very unlikely to be able to work from home. So during the pandemic, there's very common to see the multi-generational household in our clients, for many reasons, for finance, for easier to take care of under the same household. So then, but then turns out there's a lot of conflicts because of the living arrangement. That there's a lot of self-blame. Maybe like I didn't care enough with my minor children, my nuclear family. I didn't do enough with my parents, and I can totally see the dilemma that they are facing. So Self-Help for the Elderly, we provide assistance to the caregiver through case management, like information assistance that link the caregiver to the right resources, counseling, care training, caregiver training that we know what topic that they choose, and we would do survey, then they can suggest topics that they really interested in. And we also just done field trip to Winchester Mystery House with 30 caregivers. We took a tour bus, and then they were so happy, they were thrilled. And surprisingly, many caregivers said they'd never been to San Jose. They've been in America for many years, decades, but they only stay in San Francisco. They're so happy that they were able to travel, and they actually experience what self-care means. So I want to take this opportunity to thank all the caregivers for their dedication, and you're not alone. And if you need help, you seek help, and we all do this together. And we also provide like caregiver training at our Self-Help for the Elderly and other supportive services that would actually be with all the caregivers. Thank you.
Thank you to the panelists for those excellent presentations. And again, if you have a question, please jot it down on a note card and just hold it up, and somebody will come and get it. And so, because I gave you the first question, I'm not going to ask that question because you might have been making notes. So instead, I'm going to ask a different question. But I'm going to direct this actually to the physicians on the panel, because you're actually relatively younger. And I wanted to ask you about your medical education and whether these issues came up in your medical education, and should they have come up, given when we look out, into the future, the future really is oftentimes, is addressing chronic care conditions in general. So to think back on your medical education or continuing medical education, because everyone needs to, continue education for their license, and it's required. Should there be some sort of requirements that this is woven into their continuing medical education if it wasn't offered during your medical school experience? So could you comment on that if you have some thoughts about it?
answer. There. Okay. So the short answer is no, this is not covered. And it certainly should be. I would say to the extent that it is, it's usually covered too late. So it's covered in the circumstances of how do we engage family caregivers and support persons at the end of life in conversations around advanced cancer and palliative care. And that's really a tough space to start thinking about these issues. It's not the ideal situation. It's not an effective situation to begin to engage family members and caregivers. And so, yeah, there's not a lot of time spent on this at all in medical education, in training, in residency, and throughout. And we need to find ways to build it into the training and into what we do. And that is a lot of what we hear and what I've heard from other providers and physicians is that they just don't feel comfortable in this space. They also don't know how to navigate the tricky aspects of how you sort of pull together this triangular relationship and how do you kind of move care forward in this space. So I think there's a lot of room for improvement on this.
I would just add really quickly, no, again, that there's not really a lot of training. I probably got the most training in geriatrics fellowship. So that was, I did my medical school, I did primary care residency, and then a fellowship. And that's where I really got a little more education. To put it into context, we didn't have any geriatrics education in our medical school curriculum, and the faculty were successful a few years ago in getting I think we had like a week or a few days, and they got a 2-week intensive where they also go now, the students all go, UCSF med students now all go on site to different living situations, and they learn a little more about caregivers. So, but that's UCSF, and I think medical schools in general probably are mostly doing a abysmal job in terms of adding caregivers to the curriculum. For our dementia care aware curriculum, where we're offering CME, so that's a tiny incentive for people to get those continuing education credits. Dr. Semere is developing training for us to put into that curriculum and put out there. So we're going to be heavily promoting that. So, but it is a great question and an important concern.
I was just handed a note that there's a Senate Bill 48 by Lyman, that would require all general internists and family physicians to complete at least 4 hours of continuing medical education on dementia every 2 years as part of 50 hours of CME already required by existing law. Yeah, we're aware of this, and we're really happy to support this.
So it's going up now?
It's passed.
I think, unfortunately, that is the bill that started Dementia Care Aware, but it's only for providers who are doing Medi-Cal assessments for Medi-Cal patients who don't have Medicare, which is it's different. All right. Well, thank you for educating us. Okay.
Yes, California is the only state in the country that has passed a bill requiring that general educators have to have some dementia training.
Yeah. That's great. Thank you for that clarification. It takes a village to understand what's going on as well. This is not a question, but I do have to read this. Don't forget. Take care of yourself before you can care for someone else. And the importance of having a sense of humor. I second that entirely. I'd like to just go back and just ask about the getting local here for a moment, the approaches and strategies. The first question I started out with for the city and county of San Francisco to raise awareness about family caregiving, especially in underserved communities and communities of color, and anyone can take a stab at that.
I love how the microphone just made its way over here. Okay, so I think we are doing many things. The biggest thing that DOS can do is it's with our partners. It's with all the CBOs out there who have the language capacity, cultural competency, and we are really working together with our community-based organizations to figure out, and it's a conversation that goes on forever, how to reach those who are hard to reach, right? And it's going to be different on every block, and it's going to be different in every community. So what we can do at DOS is we are also trying to partner with those smaller organizations who might not have, these huge resources, but we can offer some technical assistance because they are actually reaching a group that we haven't been able to reach before. So we are doing that. And then for those caregivers and those who need assistance, who are able to walk into the hub, we have we do have the language capacity, so we think that that is really important. The other thing is working with Homebridge and working with the public authority, who the public authority has their one-stop resource center for caregivers, and Homebridge is really rolling out I want to get the name right, sorry. A IHSS Career Pathways Initiative, which finally is recognizing that, like in the olden days, not even so olden, folks would be caregivers for a while and then go apply for a job, and people, well, what have you been doing? As if, right? So now there's this, you have been working really hard, harder than everyone else who's working in this 8 to 5 job. So we're trying to find different ways to engage the community and just to get people to show up for themselves.
Yeah, so we have, I forgot to mention about the supportive services that we have. And one of the services we have was Senior Escort Services. And it started back in 2021 March, and because of the increase of anti-Asian hate crime, and we realized that the safety is important, and it's heartbreaking to see the attacks target on seniors, and so we provide escort services for seniors throughout the San Francisco, and it doesn't limit to any ethnicity, and any senior or adult with disability will be eligible to the program. So we have received tremendous demand for this service, and we have already helped close to 1,000 unduplicated clients, and thanks for DOS for funded this program. And so the typical escort activities that we usually get is medical appointments, chemotherapy. We have assist caregiver and also the care recipient to attend chemotherapy, and it's pretty intense. It's back to back every day, and then for 2 months, and then so we have 2 vehicles, so we can either take transportation with the client, or we can provide transportation to the seniors and caregivers, so that in a way would be able to help reduce some of the burden from the caregivers, and we can take a walk with the seniors, or go to the bank, blood work, CT scan, and then sometimes surgery too. And we also know that it's hard to start the conversation for advanced care planning and fill out the form, but we know that it's essential for patients and also the caregivers and family members as well. So we also be able to conduct outreach and actually provide assistance to fill out the form for who is interested in. So I hope these resources will be helpful, and then if you have any question, feel free to reach out to us.
Thank you. Well, I'm just tossing away all of my questions that we did because your questions are so much better. And there's a question that sort of speaks to sort of a larger issue. Caregivers are leaving the city, and what can the city do to help? I'm assuming these are paid caregivers to help to help the San Francisco caregiver stay in the city. It's really a crisis. We have an enormous workforce shortage right now. For direct care workers. And I'd like to, and I know this is, particularly true. I've chatted with the Homebridge director, Mark, can't remember his last name, Burns, thank you. And he just says, they used to have, 40 to 50, 60 folks walk in looking for work, and they just don't have anyone coming in through their door. So I want to, talk about the workforce shortage, particularly in the direct care workforce, because even if you wanted to hire somebody, there may be nobody to hire. So I don't know, Kelly, if you want to start off the conversation, and we can take it from there.
Oh, okay. Yeah, we're in a really bad way right now, and it's really in all. It's not just in caregiving. It's in, the city has a really high vacancy rate now. We're having a really hard time finding people. We all know what the answer is. We all know what the answer is, right? Housing, maybe. So I think everyone is concerned about this. You can't expect people to work for nothing. You can't not pay people and think that they won't go away. So I know that we are doing what we can around incentives, but it's really hard. I mean, pay obviously needs to increase. We obviously, I think, through Homebridge creating this CNA pathway, so that people they'll have even more that they can do. They can get into higher employment or more. Not that this is not high employment, but you guys get what I mean. So I think the big issue is that it's too expensive for people to be able to live in San Francisco, and then it's too expensive to be able to do the commute from the far reaches of the Bay Area to get here. And until that changes, that's all gloom and doom. I know. I don't know what the answer is. We are all struggling. All nonprofits are struggling. The city is struggling. We can't find caregivers to find people. And we don't talk about it enough, the need for caregivers. So until that happens, we're just all trying to find people and hold on to the ones that we have.
You have to agree. I think it was on the radio this morning as I was coming here, there was someone talking about how her work as a CNA at a skilled nursing facility was paid at $15 an hour, which is, so it boggles the mind, and it doesn't make sense. I think there's that famous quote about the system gets the results it's designed to get, and we have a system that undervalues caregiving and at the moment, overvalues real estate, I guess. So.
Yeah, I think I would just echo those comments. I think we just haven't fixed the root issue, and that's the problem.
Yeah, I see this trend of getting harder to recruit or hire caregivers. So far for the elderly, have a neighborhood access point that we have a pool of caregiver candidates that looking for jobs, and then and also we do referrals for employers who are looking for caregivers. Some of the caregivers already registered with IHSS, and then could be private pay or under IHSS. So that's the neighborhood access point that you can make a referral request and trying to find caregivers. And we also started the home health aid training, and we start a caregiver training academy with self-help. So with that, you could get the CNA certificate or get the home health aide and also nursing assistant certificate. It's at no cost, no tuition, and then it's one way to support and trying to have more caregivers that build their career. And there is also the caregiver training workforce support that's taught in Chinese that actually target caregiver with limited English skills. And that's a way that could make them competent for the caregiver skill set. So it's also what we are trying to do too. Thank you.
I was just reminded that we're making notes of the questions and answers. I'm going to do a summary so that can go out to everybody in case you didn't catch the answer. I have a question that is directed around the flow of information during a health visit. And there oftentimes, I think it's probably more than 50% of the time, an older adult is accompanied by a family member or a caregiver, in visitation to their physician. And this question was around, I think, caregivers that may be paid caregivers, but certainly unpaid caregivers. There seems to be a communication blockage. Sometimes it hides under the banner of HIPAA, and all that kind of stuff. What do you see as maybe the barriers to that communication? Are there real barriers there? Or what can caregivers say to maybe open the barriers that is a message that they all can take away today to encourage better communication?
Okay, so what I was saying earlier, I would enter a visit and say, hi, I'm so-and-so, and I'm in this person's life in this way. If we finish up the visit, I would like to get the information. I prefer written information. I prefer, if you could do a voice memo, that would be great, so I can listen to it later. I start out visits talking to the patient, asking them who's with them, how should I involve them? Do we want to have the visit together? Do we want to split up? Do we want to do both during the visit? Because I do consults, I have more time, and obviously I've had a little more training and awareness building. But I think most of the doctors you go in to see are going to be utterly clueless, and I say that with love and admiration for all the things their brain is doing the rest of the time. But they're not thinking about it in a structured way. And we have structurally shut out caregivers because all these rules that you point out, that then just confuses everybody. Am I allowed to talk to the person if I don't have express permission or not? And I do work with a lot of folks who bring somebody who they do not want involved actually in their medical care. It's someone who's supporting them to get to the visit, but they're just sitting there because my other coworkers put them in the same room. So I do open up with, how should we be doing this? I think it's just, unfortunately, there's not enough awareness, there's not enough structure. Everybody's winging it. And so I really you have my firm support to just, open up the visit with a declaration of who you are and how you'd like to be involved in the visit, and that will help them. They won't see that. Generally speaking, I would think they wouldn't think that's rude. And or the person who you're with and is you're caring for or supporting that day, do you want them to say that? Do you want to have a plan as you go in there? How are we going to introduce ourselves? So many assumptions are made. So, and it's not intentional. It's just the way human interactions work. So I don't know. Thank you guys in advance for taking that initiative and helping along your poor medical teams who are really struggling. Dr. Semery said that was good.
We also have a comment from an audience member about this particular topic. The simplest solution can be the best. Require any medical appointment scheduling to ask if a caregiver is involved with the patient, and can they be available in person or on phone during the visit. Every doctor should see the caregiver name on the patient summary form and ask first in the visit, is this person available? This reduces your vague patient understanding of doctor's directions to improve compliance. So that's another great suggestion. Okay, I'm going to have time for one more question. They're all so good. I'm trying to select between the children here, which one I should read. But here is a question that we actually haven't addressed yet, and that is for older adult caregivers, and also those that actually are without family. And this is a really tough issue to talk about because you may not have a family member present. Have anyone given some thought to how we support communities of care, or however we can put those kinds of communities together?
I'm not trying to monopolize the microphone. I think briefly, so I see that often, and people's lives shake out differently, and I do point out. I always preface and I say, I'm going to ask some nosy questions because I just want to know a little bit about you and know how I would kind of insert myself to help you or offer things that might be help. And if they tell me, I really don't have anybody who I consider close or that I really rely on, and so I can't really help with an emergency contact or someone who we can work with to do a healthcare proxy or, indicate as my surrogate. So I just start pointing out some resources that they may want to consider to help protect them, because we do live in a bureaucratic administrative world where if you are in an emergency and you can't communicate for yourself, this healthcare proxy issue comes up. And if you are in that situation and you don't have a healthcare proxy, you are potentially what we call unrepresented in that moment, and you're highly vulnerable to everything the system wants to do to you. So we need to start helping you at least get some documentation of what's important to you. How do we get your voice to come through your records to show who you are, what's important to you? So at the very least, physicians, healthcare systems can work with you. And then there's issues. What if you do start to have some challenges with your thinking or your memory? There are services out there that could potentially support you to manage your finances and make sure you don't end up missing your rent for 3 months or something. And these are really hard things to talk about. I don't jump out of the gate with it, but I do start the process of understanding the social network because many, many people don't have those people to rely on. And we are lucky in San Francisco. It's not, nowhere is, I imagine, is it perfect, but we do have a lot of resources that I can then encourage people. And I will say just one last thing is that, yes, there's healthcare considerations, there's bureaucratic considerations, there's a lot of legal considerations. So I start referring to free legal services for older people and medical legal practices, for example, through UC Hastings, because you don't want me doing your financial DPOA or like your financial power of attorney, but I do want you to get that done if that's something that's important. And so, okay, thank you guys.
Okay. Just one more wrap-up comment, and that is there's a number of questions about eligibility and what services are available, and that's why we have all of the resources around the room that can answer some of those questions. What does Medicare pay and don't pay for, and how come caregiver expenses are not reimbursed, and so on. And sometimes the answer is a little bit more complicated, and so what I'm going to suggest is we have a wide array of really wonderful resources that know the answers to those questions. And during lunch and breaks and so on, please take an opportunity to go over to the tables and ask those questions and hopefully get some answers that you're looking for. So I want to thank all of the panelists. This has been very wonderful. And I'd like to thank I also would like to thank the Brain Trust in the audience for their contributions. And we're going to move to the next panel. Thank you.
All right. Thank you. Very good. Wonderful. If you would give me your run of show.
Oh, okay.
This is when you're done.
Oh, I'm sorry. Here.
We're just going to do a little bit of a transition here. I would encourage you to stand up for a second, raise your arms, just stretch a little bit. Feel free to do that. We're just going to take 2 minutes, and we're going to invite our caregiver panel to come up to the podium, please. So that would be Linda, Richard, and Joyce, and Ephraim. Thanks, Kathy.